right, good afternoon, everyone. So I'm going to be going over vital signs today. I tried recording it on Microsoft Teams, but let me do it. So I'm going to go ahead and upload it back in assignments. So vital signs, there's four simple ones that we're going to be going over here. So the four basic vital signs that we have are temperature, pulse, respiration, and blood pressure. And generally, what vital signs are your basic measurements from the body. So let's go ahead and get into it. There's certain things before we get into each vital sign that may influence the vital signs. So physical and emotional factors, if patients are hot or cold, or they're coming in from the outside, it's a really cold morning and you start taking a surface temperature, they're going to show up a little bit colder than they would normally. Some patients, a lot of the time they do get nervous or anxious. It's known as a lab coat blood pressure. So they go to the doctor's office and they're kind of nervous for being there. They're not sure what the doctor's going to say. And their blood pressure becomes elevated along with their pulse. Okay. During the time, your patients are going to be rushing late to their visits. So you want to just ensure that the patient kind of takes a seat, relaxes as best to their abilities. And these patients usually know who they are when their blood pressure is raised because of their nervousness inside the office. All right, so getting into temperature, certain factors that can affect temperature. We have age, stress and physical activity, gender, and other external factors. Okay, also another sign is fever. So we have a continuous fever, intermittent, which is here and there, or remittent. Okay. So with fevers, generally the range that we have is anything above 100.5. So we consider that patient febrile. And without a fever, it would be afebrile. All right, so there's different locations to go ahead and take the temperatures. One is axillary, which is in the armpit. Second one is orally, so you stick it under the patient's tongue. Third is tympanic. So tympanic is going to be taken inside of the ear. And when you take it inside the ear on the adult patients, you're going to want to go ahead and pull upwards and back. And then on the pediatric patients is down and back. Okay, you just want to expose that tympanic membrane, which is the eardrum, so you can get a good reading on the temperature. And then we have rectal. Rectal is probably the most accurate out of all of these readings. Reason being is because it's kind of the internal core. So these will be a little bit different as opposed to if you take someone's temperature tympanic. Okay, and lastly, we have the temporal artery. So if you feel artery right here, this areas are the temporal artery right in here. So we kind of surface the thermometer straight across and then go down here, hold it for a few seconds, and then we'll go ahead and get our reading. All right, so characteristics of a pulse. So when we're talking about a pulse, that's how many times your heart beats a minute. Heartbeats fall as blood moves through the arteries. So the arteries are a lot thicker. Arteries are the blood vessels responsible for taking blood away from the heart. And the rate that we measured is always 1 minute, okay? Generally, when you're acquiring a patient's pulse from the radial artery, which is here on the wrist, we could go ahead and count for 30 seconds and multiply it by 2. But if you feel any type of irregularities, you want to go ahead and count it for a full minute. Okay. Some other factors that we have as well is the rhythm. The rhythm is the time between pulse beats. So that's where you could feel the arrhythmias or an intermittent pulse. Sometimes you might feel like it's kind of thready. And then we have volume, which is the strength of the heart as it contracts. So when we're getting our pulse here, that's when the heart is contracting. Different locations to get the pulse side. So the temporal is another region where we can get the pulse. If you actually feel it right here, lightly, you can feel the actual blood going through the arteries, and each kind of thump is the that would count as 1. Okay, then we have the carotid here, then we have the brachial right here, radial, which is probably the most. It's always going to be thumb side. Okay, so radial will be lateral to the midline of the body right here, so it's on the thumb side. And whenever you take a pulse, you want to make sure that you're using 2 fingers, okay? Because your thumb has a pulse, you want to be measuring with these 2 fingers. Femoral, which is in the thigh, that one's a little bit harder to feel. Popliteal, that one's behind the knee. That one's not too difficult. And then we have the dorsalis pedis, which is on top of the foot, okay? But generally, we're going to be going ahead and taking the pulse on the radial artery. Now, if you have a patient that's unconscious or they're in a kind of emergent situation, if you don't feel a radial pulse, go ahead and go to the carotid artery, which is here on the neck, and try to feel the pulse there. All right, so these are the pulse rates for the different types of patients and their ages. So newborn patients are going to have a higher pulse. So it's about 120 to 160. So their heart beats a lot. Then when it gets about the 1 to 2 year range, it's about 80 to 40 beats a minute. 3 to 6, 75 to 120. 7 to 11, 75 to 100. And then from adolescence to adulthood, about 60 to 100 beats a minute. Okay. Now, these are just standard ranges through the American Health Association, but they can vary based on the patient. You know, some patients are taking specific medications, you know, their pulse may be higher, lower, depending what it was. If you just gave a patient, you know, an injection of what's the medication for allergies? The auto-injector for histamine, epinephrine, my apologies. So epinephrine, their pulse is going to be extremely high. It's going to be shooting through the roof along with their blood pressure, okay? Now, when we're talking about Olympian athletes, if their pulse is about 40 or 50, it possibly might be normal for them, okay? The thing we need to understand as medical assistants is that we keep a good range, or I'm sorry, keep a good flow chart of accurately measuring all of these different pulses. All right, so how do we determine the pulse rate? We have the radial and the apical. So the radial is the one with our fingers, 2 fingers here on the radial artery, and apically. So when we take a pulse apical, that's going to be on the apex of the heart, right inside here. So you don't ever want to physically touch the patient with your hand like so. You're going to go ahead and just put your stethoscope on, and then you just feel it with the stethoscope right on the apex of the heart right here. Okay. The other ones that pretty much don't try to use are the femoral and popliteal, the pedal arteries. You can feel a pulse. Sometimes we use these if, you know, if we're putting tourniquets on a patient's lower extremities, which you will not be doing, but that's just to kind of ensure that the, you know, the tourniquets are actually effective, or if you're putting a pressure bandage to make sure that that patient still has a pulse to make sure that nothing's cutting off circulation. All right, so when it comes to respiration, when we're talking about respiration, the physiology of it is inspiration. So, and then expiration, which is breathing out. So internal and external, now that counts as one respiration. So breathe in once and then out. So that counts as one, okay? It's different characteristics of respiration. Sometimes the patient might have, you know, lateral respiration, you know, where one lung is going up and the other one's not. They might be, so from tachypnea, which is an excessive amount of, they're hyperventilating, and where they could have dyspnea, where they have difficulty breathing as well. All right, so the way we can characterize is by normal, rapid, slow. So we can determine, is it fast, slow? Pretty much that's how we determine the rate for respirations. Breathing alternations, so are they breathing in patterns, or they kind of, you know, so we can go ahead and see that as well. And then the response to exercise or emotional upset. So some patients, you know, obviously for exercising, our respiration is going to be a little bit higher. Patients who are in like a nervous situations, their respirations might be higher as well. So you have to be cautious of that. All right, so the rhythm are the breathing patterns, and the depth. The depth is the amount of air inhaled and exhaled. Sometimes you might see shallow breathing. Sometimes you might see super deep breathing. Now, the different age ranges for respirations. So newborns, it's going to be a little bit higher as opposed to adults. I'm generally worrying about adults when I'm teaching the class, but it's good to know these ranges when you work if you ever work in pediatrics, but I'll cover these in class. And then we have 1 to 3, which is 20 to 30, 4 to 6, which is 18 to 26, 7 to 11, which is 16 to 22, and then adults, normally it's 12 to 20. So if you have a patient that's their breath count is above 20, they're going to be considered tachypnea, and then if they're below 12, it's going to be bradypnea. Okay, so brady meaning under, tachypnea meaning excessive or higher. All right, so counting respirations, don't walk to the patient and say, hey, I'm going to go ahead and count your respirations. What we technically tend to do is just go ahead and count the pulse for 30 seconds, but still leave your pulse, still leave your 2 fingers on the pulse as if they believe you're still taking the pulse, but you're going to look at the chest rise and fall, and then that's when we count the respiration. So for those other 30 seconds, you're counting the respirations. So the first 30 seconds, get the pulse, remember it, And the last 30 seconds, get your respirations. You multiply both of those by 2, and that's how you annotate in the patient's chart. So it's going to be per minute. All right, so when we're talking about blood pressure, there's different factors that affect blood pressure. So we have systolic, which is the top number, and diastolic, which is the bottom number. This is the different ranges for blood pressure with newborns. A little bit opposite of the pulse and respiration. This was actually going to be lower. Okay, so lower than your adults. Newborns are about 60 to 96, 46 to 78 to 112. Adults, you have 100 to 119. Okay, anything above 119, so 120 and above is considered elevated blood pressure. All right, so you have different stages of hypertension. Normal, it's going to be less than 120 to 80 millimeters per mercury, and that's what this mmHg means. Elevated, 120 to 129. I know some places may consider that pre-hypertension, but the American Heart Association does go by this. Not saying that these patients are going to be put on medications, but it's just something to kind of make them aware. Stage 1 hypertension is known as 130 to 139. And then we have stage 2, which is 140, or the diastolic is at least 90 millimeters and above. Okay, so that's kind of very important there. The diastolic, which is the lower number, that means this patient's heart is working pretty hard to get the blood through the arteries at a resting rate. So the difference between the systolic and systolic is a contraction of the heart, and that's the amount measured of the blood on the sides of the arteries. And the diastolic is when that heart is relaxed, and that's the amount of measurement on the arteries when the heart's relaxed. Okay, so systolic generally should always be your higher number. Diastolic should be the lower. Anything over 180, or any systolic over 180 and any diastolic over 120, that's hypertensive crisis. So that's when some measures need to be taken. Some patients I've seen come in, their blood pressure is extremely high, and that's just how it is, or they just have slammed a coffee, energy drink, whatever it may be, but do notify your doctor immediately, okay? All right, with the American Heart Association guidelines, we already went over the different stages here. Okay, so over 50, they're treated for their systolic pressure. It might be over 140. So that's usually when medications are implemented. Okay. All right. So the blood pressure we measure with the Sphygmomanometer. This one's regularly calibrated. Make sure your sphygmometers work and just check for accuracy. Usually within 3 millimeters. You can verify that with an electronic one. But do know how to take blood pressure manually. Even though a lot of these clinics they have their regular, they have electronic blood pressure machines. We're going to usually do it manual at certain locations. Batteries may run out, whatever it may be. So you just want to ensure that you're doing it correctly. And then we have the blood pressure cuffs. They come in different sizes. So a 4-year-old wouldn't get the same blood pressure cuff as what a 12-year-old or 18-year-old, things of that nature. Sometimes when it gets really tricky is when you have, patients who are overweight, obese, whatever it may be, you may have to use a large thigh cuff. Okay, so, but do have it on hand. Don't make the patient feel insecure about anything. Just have it easily accessible and just switch them out. And sometimes you might even know that which patient's coming in. So already have the cuff on there beforehand. All right, these are different cuff sizes out there. Don't just have one cuff size for everyone. Patients come in all shapes and sizes, so have multiple. All right, some other things you want to make sure that your patient is either sitting up or in the supine position. So if they're laying down, sometimes the blood pressure can change up to 5 millimeters per mercury. Make sure your patient's not crossing their legs, and make sure the arm is correct at the level heart. So you usually want them, having their arm out here is usually fine, straight ahead is usually best. Does it always have to be the left arm? Not necessarily, it can be the right arm, but just make sure that it's completely level with the heart if you can. All right. Some other areas that the bladder is not completely deflated before the reading is taken. It's released too rapidly. The patients that are nervous or anxious, drink coffee, cigarettes, any type of methamphetamines, drugs, things like that is going to elevate the blood pressure. But that would be a normal blood pressure. It wouldn't be kind of an error. The cuff is too large and not placed around the arm correctly. So make sure that you put it correctly as what the cuff says. According to the artery, there's going to be an arrow. And when we're in class, I'll show you specifically how it's measured. All right, so In regards to vital signs, just make sure that you're accurate and safe thermometer use. You're using the correct thermometer for the correct route. So don't start using a rectal thermometer to take a oral temperature, even though they might be the same. Make sure you change the probe out. We know how to use which thermometers for what. When it comes to obtaining the pulse, make sure you're accurately using the correct artery. Track your respirations. Make sure you you don't tell the patient you're going to record the respirations, but you let them know, or are you just aware what's a normal count, so 12 to 20. And then measuring blood pressure, know what systolic, diastolic is, and the patient's going to ask you, well, is that good? Is that bad? What does that mean? So make sure you know how to explain blood pressure effectively to them.